Peds Pod.
Hello and welcome to this month's episode of BRHC Peds Pod. I'm Ruth Bowen. I'm a Bristol GP working for the BRHC Training Hub, bringing baby, child and young person education to primary care clinicians. This month I'm joined by J-C Sconce, who is General Paediatric Consultant at Bristol Royal Hospital for Children and the co-author of the Gastro-oesophageal reflux in infants guideline at the hospital. And some of you might remember that she came to speak to us previously about nocturnal enuresis. Thanks so much for joining us, JC.
Thank you for having me.
Without further ado, we're going to delve into 3 cases to ground our learning and think about some of the key questions that we should be considering in primary care that dictate what we should be doing next. So first case, parents present with 5-month-old Skylar, who's been positing small amounts of milk after most feeds for the last 2 months. She's often upset immediately after feeds, and this can last minutes to an hour. Mum's feeling exhausted by the relentlessness of it, and friends have suggested she get treatment for reflux and considers weaning. There's no blood, bile or projectile nature to the vomiting, and Skylar has 1 to 3 dirty nappies per day with occasional straining. She's exclusively breastfed, tracking the 75th centile for weight and 50th to 75th centile for height. Skylar was born at 39 weeks by elective section with no pre, peri or postnatal complications. She lives with both parents, although Dad does work away a lot, has no siblings and no significant family history of note. Skylar's settled, smiley and interactive, and examination is unremarkable. So JC, what are your initial thoughts with this case?
Well, I think that gastroesophageal reflux is likely to be the top of the differential list. I'd be keen to understand when she started to vomit and whether that pattern in vomiting has changed. I am, however, exceedingly reassured by the fact that she has a normal examination and she's thriving on her growth charts. So I would start by doing the top-to-toe examination, looking for any red flags, establishing the history in terms of when the vomiting started and if it's changed at all. I'd also be very keen to watch Mum's interaction with the baby, get a feel about how she's coping, particularly as Dad is away a lot of the time.
Can you talk us through complications of gastroesophageal reflux in infancy that you'd want a primary care clinician to assess for?
The complications that we list in the guideline relate to weight being the primary one, so children that start to falter with their weight gain, which can be associated with food refusal, or that may be a separate entity. Those are essentially associated with the esophagitis, which is the presumed complication of the reflux. You don't often see physical signs of actual esophagitis. Very rarely will there be any blood visible in vomit, and generally those children are referred in a much more urgent manner. There is also the issue of respiratory symptoms, where some of the children may be silently aspirating, but again, this isn't in a straightforward normal baby who has normal development and has been growing well. So they're slightly rarer complications. So the commonest ones to look out for are essentially the weight of the child, the ability to feed the child easily, and in association with that, Mum's ability to cope with this child.
Thank you. And how common is reflux in infancy?
Unbelievably common, and I think that's why Mum's had some of her friends talk to her about it, and I think that's really important that she feels this is a normal phenomenon. So there are some statistics out there that say it's almost daily occurrence in 70% of babies in this age group, and that 5% of those affected will have more than 6 episodes a day, and that means by vomiting and crying in terms of when they say episodes. So it can be really pervasive symptoms, and they can be really exhausting for the family because the baby can be very, very unsettled, and it can make being a new mum, particularly if you're a first-time mum, quite a miserable experience. And that's one of the things to be aware of. But whenever we diagnose reflux, I always tell them that they will grow out of this. So 90% of them will have grown out of it by the age of 1 year. And there's a significant improvement around the age of 6 months when they're starting to sit upright. So gravity starts to help the process, but also they're weaned on solid food. One of the non-pharmacological managements of reflux is to wean them early. And that's something that we could talk about, which has already been mentioned to this mum by one of her friends.
Thanks, that's really helpful. And actually thinking about the fact that it is normal, I say in inverted commas, and what they can expect is really helpful. So I had a little one who had quite bad reflux, and just knowing that actually there was the next step and the next step. Once you get to weaning, once you get to sitting, once you get to a year, things would get better. And just knowing that, I think, can be really encouraging, where it is a real struggle.
It can be a real struggle, and especially if it's your first and there isn't anyone else around to provide you with that reassurance, you will start to think you're doing something wrong. Normalisation by either friends, peers, medics and health visiting team can be really, really helpful. mums will often realise that they can do things to make their baby feel better. So they'll hold them upright after feeds, but then they get into this cycle of never being able to put their baby down. I do talk to mums about using dummies in reflux babies because it does seem to help. So if they're well established on breastfeeding and it's not going to cause any issues with their breastfeeding, I do talk to families about using dummies because what they do is they constantly swallow, and it does seem to help their symptoms a little bit and it settles them. So if you're trying to stay away from pharmacological management, those are some of the things you can do. But it's key that you do keep an eye on this baby's weight, which can just be done in the health visitor clinic. They don't need to be seeing a medical practitioner for that.
Oh, brilliant. That's a really good tip about dummies. I hadn't heard that one before.
Yeah.
In terms of how you'd want the clinician to manage Skylar, so you've already talked a bit about normalising and explaining what to expect, the health visitor being a really useful resource there, and some non-pharmacological management. Is there anything else that you would want to do, particularly within non-pharmacological management? Any other tips that you might give mum?
I would say at 5 months that if she has good head control, that she should start weaning her very slowly, but to explain to mum how this can help with the reflux symptoms. And it will take weeks before she's on to any significant solid intake where she's starting to swap solid food for milk feeds, as it were. But it does seem to help with their vomiting and their symptoms. I would ask her to have regular contact with her health visitor to help support her.
And is there much evidence behind the non-pharmacological strategies?
There's really limited evidence about lots of the stuff that we have, but we do know that this is a self-resolving diagnosis. And so essentially, if you can support the baby through this with as limited intervention as possible, then they will get through it. The ones that don't get through it tend to declare themselves very early. So the babies that really are faltering, you will know about this those first few months of life as opposed to around 5, 6, 7 months of life. And so what I find when talking to mums is actually they're much happier to engage with the non-pharmacological treatments because they're doing something actively themselves and they're not having to give a medicine to their baby unnecessarily. And in fact, what we do sometimes find is a resistance to use pharmacological treatments, even though there is good evidence that it can be helpful. But they will generally take that advice on board and start medication if it's truly indicated. It's essentially supporting them and holding their hands through until they grow out of it. And whatever systems you've got in place to do that, whether it's health visiting team, there are some forums out there. Again, some caution around that. But essentially, you need other mums to tell you, you will get through this.
Yeah, and actually just having some strategies to try can give them something to focus on where they feel like they're not just ignoring their baby's cries and their baby's needs. I know I certainly tried quite a lot, and I remember the whole putting the cot at a tilt, to which my little one would then just turn around, so he was then head down. So, but it's still just things to try, isn't it?
Yeah, absolutely.
They're not all going to work for everybody. But...
No, and the cot tilt one, we just must say that you mustn't put stuff under the mattress. You must put stuff under the cot legs. But yes, we do suggest that. And often families have already done things like that. And you'll often know because they walk around with them in a sling all the time because they've got them upright because that's where they're happiest. But yeah, those are the things that they can do. And I think if mum is showing signs that she is not coping despite the lifestyle features, you could then start talking to her about pharmacological treatment. This would be not obviously indicated for the baby's health needs in this scenario, but it may well be that you're helping to support mum. First line treatment is Gaviscon, but this can be really difficult to deliver in a breastfed baby. And the next step would be a PPI, such as omeprazole or esomeprazole.
Thank you. Is there any safety netting or follow-up advice that you'd want to see in this case?
So I definitely would want them followed up by the health visiting team. And I think it's worthwhile mentioning to the family at this stage, particularly for a mum who's on her own a lot of the time, about the ICON training that's out there, which essentially tells mums that it's okay to leave your baby to cry at certain times once you've checked on them and made sure that there's nothing that you can see that's bothering them, because it is actually okay to let your baby cry for a little bit. I think it's really important that we all acknowledge that, because there are some parenting thoughts about that you should not let your baby cry at any points in time. However, that is pretty much impossible with a baby who has reflux.
That was essentially a very typical case of a physiological reflux with no complications, so really good to get your thoughts there. Moving on to our second case, mum presents with 4-month-old Leo, who she reports has been a posity baby since birth, but has got significantly worse over the last couple of months, bringing up half his feed every feed, and coming on and off the bottle or breast distressed. He's still feeding 2 to 3 hourly, by breast during the day and then a bottle in the evening. Mum describes feeding as a battle, and Leo is now starting to reject the bottle. There's no blood or bile, and Leo is producing 5 wet and 3 dirty nappies every day with no blood or mucus. Pregnancy and birth history are unremarkable, with no significant past medical history or family history. Leo's alert and settled. His birth weight and weight at his 6-week check were on the 50th centile, but today he's between the 9th and 25th. Examination is otherwise unremarkable. So what are your initial thoughts with Leo?
So I have got more concerns about Leo. The sentence about feeding becoming a battle is a red flag for me, because if they're starting to really come off the breast or refuse the bottle, you are going to very quickly tip into a territory of food refusal or oral aversion that is associated with reflux disease. He's not quite hit the threshold of faltering weight gain, as he hasn't totally crossed 2 centiles, but he's very close to doing that. For me, in this scenario, I would again do a top-to-toe examination, make sure you're not missing any red flags. But if we're considering a diagnosis of reflux, I would have a lower threshold to start medications. Now, he is a mixed-fed baby, breast and bottle, so there is the potential to start some Gaviscon with the bottle feeds. But I would be very quick to add in a PPI in this scenario to try and get on top of his symptoms quickly before we develop any further complications. This isn't strictly relevant for this case, but there is something worth doing about, particularly for the bottle-fed babies, is making sure that they're not being overfed, those that present with vomiting, and not quite so distressed. Anything over 150 mils per kilo per day is generally too much milk. It is useful to be able to work out what they're having, and reflux babies do like to drink because it makes them feel better, and so therefore they feed often and then they vomit up. And overfeeding can always be a part of this, and so just being aware of that is important. So I would have low threshold to start on the first line treatment, which was Gaviscon, and very quickly add in the PPI. And it may well be that I would even suggest that you do both at the same time, because he is a mixed breast and bottle fed baby. And so therefore you won't get the full doses of Gaviscon in, I would have thought, realistically. So we'd start those medicines and refer in, and we would see. And at that point, we can support with dietetic support regarding feeding, as well as keeping an eye on their weight.
So you would want us to refer Leo?
100%, yeah. If you're already on a PPI within primary care and a baby that's starting to have oral aversion and faltering weight gain, you're going to come to the end of your options very quickly if they don't improve on that initial treatment. If they get to us and they're improving, great. We would be happy to then hand them back. But I think there is benefit in referring so that we can look at them and decide if they need any further intervention, such as a pro-kinetic, or consideration of alternative diagnoses such as cow's milk protein allergy, which does go hand in hand with reflux, and so therefore needs to be thought about, particularly if it's difficult to treat. We will also, on occasion, go higher on a PPI dose, but only once we've decided that they absolutely need it, and we wouldn't be advising primary care to do that.
Okay. So you've mentioned the Gaviscon, the omeprazole, referring in. Is that the extent of it, or is there anything else you'd want to do on top?
So being realistic about wait times and clinic appointments, we would prioritise him to an N2, which would ideally be within 4 weeks, but it may be slightly longer than that. So what I would suggest is that there's another wait done at 2 to 4 weeks, and this can again be done with the health visiting team, just to watch what's happening with his weight. I would try not to feed maternal anxiety, but I would ask about a bit of a diary of feed volumes and things, although most people are very good about having an app on their phone now that tells you exactly how much their baby is drinking and pooing. That can also give us a bit of an idea of exactly what's happening. That's what I would expect primary care to do. And if possible, engage the health visiting team as well to help support mum as we go through this.
Fantastic, thank you. And can you talk us through the pharmacological option, the Gaviscon, the PPI, anything else that might be available to us?
Yep, so we previously had access to the H2 receptor antagonists, the ranitidine, but those are no longer available and they don't seem to be on the horizon coming back. PPIs are essentially the mainstay of our treatment, so there's omeprazole and esomeprazole. And then there are pro-kinetic drugs that we use, so domperidone being the commonest, but we would certainly suggest that that is only started in secondary care level setting because they need an ECG prior to starting and 1-2 weeks after starting the medication. It is used much less commonly than it was previously because of the long QT associations, and it has shown that you can manage babies without it, which is good news. And one of the other things that we may do at secondary care level, if there's significant oral aversion and ongoing faltering weight gain, is to start NG feeds, which is another pretty dramatic treatment for reflux, which we rarely have to do, but on occasion do have to do.
And what about thickened feeds? Do they have a role to play?
They do have a role to play, not in breastfed babies, clearly, but in bottle-fed babies, you can buy pre-made thickened formulas, so the reflux varieties of all the standard formulas. They do have a benefit in that it is easier for the milk to stay down. It's not treating the esophagitis. It is more to do with the physical act of vomiting. Lots of reflux babies vomit and are not bothered. So if they are purely vomiting and are thriving and are not in pain, you don't really need to treat the symptom of vomiting. So yes, they do have their place, but I would be really careful that we explain to mums that if they're going to go down that route, they need to change the teat size on their bottles, because it is very difficult to suck out of their normal teat size, and they will need a bigger teat size, because otherwise all that happens is they get very frustrated drinking, swallow lots of air, then have sore tummies because of that, get cross with the bottle. It's a very simple treatment, but benefits are slightly questionable, because what you're trying to treat there is vomiting. And I don't mind a baby vomiting if they're growing and they're happy. But if mum is going bananas because she can't cope with all the washing, she's finding it really, really difficult, then that is something that could be done to try and help ease that symptom.
Then you have the potential of the constipation that I always worry 100%. About making things
so,
worse.
Yeah, Gaviscon and the thickeners both come with the warning of constipation. And actually, that's why I have slightly changed my prescribing practice of Gaviscon, particularly in breastfed babies. Number one, it's almost impossible to give. And number two, the mums just say it's not worth it. It is worth having that conversation with them so they know to expect it, and they know that if it's not providing enough benefit, that there's another treatment that we can suggest with them.
And would you consider the thickened foods and the Gaviscon to be about on the same line on your algorithm? Yeah,
I think they are pretty much on the same line. I mean, the Gaviscon has a pharmacological component in terms of the alginate. It's supposed to give some relief to the esophagitis type symptoms, but the evidence for that is slim.
Okay. And you mentioned that Gaviscon is hard to give. Have you got any practical tips on how to give Gaviscon and how to give omeprazole?
Gaviscon for a bottle-fed baby is fairly easy. If you are confident they're going to finish their bottle, you can mix it into their bottle of formula. If you're breastfeeding, you need to prepare it in a sterilised bottle with cooled boiled water and give to them after the feed, which might be very difficult for some babies. For the omeprazole, it generally comes in granular form. And so what I suggested to early wean them around 4 to 5 months onwards and put it on a spoonful of apple puree. And the granularity of the apple puree seems to mask the granules of the omeprazole, and they tend to take it quite well. There is now the availability of omeprazole solution, which we can give to the under ones. And again, this is much better for the more significantly affected younger babies. We would always try and swap them from that suspension to the granules once we can get them on solid food. Because number one, it's expensive, and number two, it has a very short shelf life, and so it essentially ends up being wasted. It does take time to dissolve it. And so it is like doing a little science experiment at home. And so therefore that will affect compliance, but it is now available to be prescribed. And again, just teaching mums how to give a suspension so that it gets into their mouth and stays in. If you're bottle feeding, you could put it in the bottle if they're going to finish that bottle. But if you're breastfeeding, it's just about putting it into the cheek and making sure that the baby does swallow it, because a lot of the issues around medicines in these babies is the administration of it.
But squirting it into the cheek, that's a good tip.
Yeah.
Perfect. Thank you. And do you have any tips on weaning them off the omeprazole? So I know that your guideline says try them off it every couple of months and see how their symptoms are. Other guidelines talk about letting them outgrow their dose.
A lot of them will outgrow their dose unless if you're actively keeping up with it. But what I tend to do is get them onto a good dose, or whatever dose is controlling their symptoms. And then I tend to keep them on it till around 9 months, when they should be on 3 meals a day and they will have dropped their feed volumes of milk a little bit at this time. They're sitting up robustly, and to see if they can come off it, whether they tolerate coming off it. If they don't tolerate coming off it, I tend to leave them on it until they're 1 and then very definitively say, we should be trying you off it now. In all honesty, a lot of the families will start to forget to give it, and they notice that actually they're self-weaning off it and they stop it. And that's absolutely fine also, because they have the knowledge that we're expecting this baby to grow out of these symptoms. And so actually I don't have an issue with families going, I'm going to try them off it at this point and see how I get on.
Thank you. And then thinking about the reasons that we might refer a child to you.
Yeah.
So you've talked about the bottle or breast aversion and the faltering growth. Do you have any thresholds or guidelines there for us? Because obviously Leo hasn't yet dropped 2 centiles, so he wouldn't technically be a faltering growth yet.
Yeah, I think you can just be pragmatic about that in the referral and saying, I appreciate that he's not yet at 2 centiles. However, he is starting to have oral aversion in association with it, and I'm significantly concerned that he is quickly going to drop. The oral aversion is something that is difficult to manage, and we don't have specific pathways for, but we do have access to dietitians and to some extent speech and language to talk about what the best things are for these babies. We do need something to support these families, but there isn't really a clear pathway for them at the moment. And so it is all done through the paediatric service, although we may not be the best people to do it. We can certainly signpost once we get them in.
And we have got a separate podcast thinking about cow's milk protein allergy, but when might we want to consider that on the differential?
So I think if you have got any of the other clues that you would see in the diagnosis of cow's milk protein allergy, you would consider it early on. So if there's blood in the stools, etc. But in this scenario, when you've got difficult to treat reflux and the baby's weight is borderline or definitively faltering, then I would do a 2-week trial. So if they're already on the omeprazole and they're doing all the lifestyle factors, I would then suggest to the family about doing a 2-week trial of either mum being dairy free or going to a hydrolyzed milk. And the one that I always go to is Aptamil Pepti because it is the most tolerated one and seems to taste the nicest. Because in reality, by the time that we're meeting them, they're often quite old, and introducing a very hydrolyzed milk is just going to get refused. And so then you may end up really struggling to get this baby to take the volumes of feeds that you want. What we suggest is going to Aptamil Pepti, trying it straight off. If they don't take it straight away, is to do half and half with their normal milk, and then over the course of a week, get them into pure Aptamil Pepti and then give them a 2-week trial and really see if their symptoms improve on that. If they like the Aptamil Pepti and things are no worse, then sometimes I will keep them on it longer without reintroducing the other milk. In theory, you should always then stop it and reintroduce it to prove that your point. But if the weight is very borderline, you may not feel confident enough in making a further change that would affect that baby's weight. So they would need a close eye on them.
And that's a decent amount of time, is it? 2 weeks for that
Yeah,
trial?
I think 2 weeks is probably enough. And most families will tell you straight away if their symptoms improve. If they don't, it's not something that we totally understand and whether it is something else going on, but it would be something that's reasonable to do over 2 weeks. I'm very wary of families pulling things out of children's diets based on a suspected intolerance. And so therefore, I think a 2-week trial at any stage is a sensible sort of time frame with the reintroduction afterwards to see if the symptoms recur.
And I have about 2 weeks in my head as a good time frame for any of these changes within that reflux algorithm. Does that sound about right?
Yeah, I think that's a good thought. And actually what you tend to find is that families comply with the 2 week and then they stop it if they don't think it's working. A lot of them do. So by the time you then follow them up, they go, I stopped it. It was rubbish.
So on the podcast, Cow's Milk Protein Allergy with Nick Sargent, he talked a little bit about upper GI, lower GI and skin element of cow's milk protein allergy, saying that if you've got more than one of those elements, it's more likely to be cow's milk protein allergy. And so perhaps you'd have a lower threshold for going down the milk-free diet. Do you have any thoughts about that?
I think it's a very sensible approach. And I think if those babies do have all 3 symptoms, then they may well already be on an alternative milk or mum be on a dairy-free diet before any reflux treatments are started. The lower GI symptoms with cow's milk protein allergy and the skin changes are much more easy to recognise in that sort of diagnosis, whereas the upper GI is very similar to reflux. And so, in all honesty, to differentiate between those two based on that only is very, very hard, which is why they need more than one for the cow's milk protein allergy diagnosis. So if you get a simple baby with refluxy type symptoms, you'll consider cow's milk protein allergy, you'll consider reflux. If you don't have any of the other signs of cow's milk protein allergy, you're probably going to go down the reflux route first. If you do, it would be entirely reasonable to go down the cow's milk protein allergy route first and then treat reflux secondary.
Fantastic, thank you. So that was a case really looking at potential complications within the context of reflux. And then coming on to our third case, parents present with 9-week-old Evie, who's posited after occasional feeds since birth. But over the last 3 days, she started vomiting more forcefully, spraying the walls and causing full outfit changes for mum and Evie. It started less frequently, but is now after every feed. It looked initially like curdled milk, now more yellowy, but it's not bilious and there's no blood. Mum describes her as a little constipated, but getting more so, and thinks that she might have abdominal pain as she keeps drawing her knees up. Mum wonders if Gaviscon might help or whether it could be gastroenteritis. On examination, Evie looks settled with normal observations and no fever. So how would you want the primary care clinician to manage Evie?
Thinking about Evie, the first thing that's different about her is her age. So she's much younger and she's got an evolving sort of picture where they talk about positing and then much more forceful vomiting. So spraying the walls is a good descriptive term that makes you sit up and listen. And also the fact the vomit has changed, albeit not green, it has changed to yellow. Those sort of factors make me think you need to think about her slightly differently and that this is most likely not to be reflux. And the one differential you want to rule out in this scenario is a pyloric stenosis, which in this age group would be peak time to present. I'd ask baby to be weighed, and if there are any previous weights, just to check to see what's happened with her weight. I'd assess her hydration, so feeling her fontanelle, looking at her lips, cap refill, and then having a feel of her abdomen. Classically, you'll try and feel an olive-shaped mass in her upper abdomen. This can be very difficult to feel, but I think it's worth having a go. I think the story that relates to the constipation is secondary to her actually not feeding, and she's not opening her bowels because she's not actually absorbing very much milk. And I think that will probably be evident in her weight. So for me, the diagnosis you don't want to miss is pyloric stenosis, and really that needs same-day assessment. So we'd ask that she comes to the emergency department. And realistically, what we would do there is again assess her top to toe and organise for a very simple blood gas, which would almost certainly give us the diagnosis if she is a pyloric stenosis and in combination with an ultrasound. And we would then manage her under the joint care with the paediatric surgeons. So yeah, it's just changing your viewfinder slightly to think about what I'm missing and the fact that this one can't wait and she does need to be seen.
In the context of a suspected reflux, are there any other red flags that we should look out for that might suggest a different differential, a more serious pathology?
When you're thinking about reflux, think about the age of onset. So we tend to see it from around 2 weeks onwards. The first 2 weeks, babies don't tend to vomit. They're pretty settled and sleepy. And then it's the combination of the vomiting and the pain that you would then be looking out for. But if they're presenting outside of that age range, I think you do need to be thinking about different pathologies and trying to make sure that all the symptoms marry up and the examination is normal. So a baby with reflux will essentially have a normal examination, and that's one of the most important things. Red flags, it's differentiated into GI symptoms, neurological, and then cardiac or respiratory and other. Most will be very easy to spot. So the other is things about if the baby's not handling normally, if they've got fever, if they're irritable, then clearly you're not going to be thinking about longer term diagnoses such as reflux. Babies that have laryngomalacia, so if they have the noisy breathing at rest, again, that comes on around 2 weeks of age, we will treat with a PPI at onset of the laryngomalacia. So that's slightly different, and they may have overt or silent reflux, but we will always treat them. Clearly, if there's anything on examination that makes you anxious, so neurologically, we've talked about bulging fontanelles, big heads, small heads, or if they look a bit funny, if you think there's a genetic abnormality, then that again doesn't mean that they don't have reflux. They may well have reflux, but in combination with something else, and we would need to consider that. But for the simple GI symptoms, which is the ones that we often get referred in with nothing else, it's thinking about the age and any other GI symptoms with it. So we've talked about bilious vomiting being seen with obstruction or a pyloric stenosis. GI bleeding would be more consistent with cow's milk protein allergy. If they've got profuse diarrhea, that may well go within that group also. But if they've got an abnormal abdominal examination, again, you don't tend to see that in gastro-esophageal reflux disease. And we would be thinking about other things. You would lower your threshold for us to see them and look to do some more investigations.
Thinking about UTIs specifically, some guidelines suggest that we should be doing a urine dip in all these babies that we're considering reflux for, which I must admit I do question if they've been vomiting for that long. It doesn't really fit a UTI picture. What are your thoughts on that?
I completely agree. If you have a baby whose behaviour has changed and there are other signs and symptoms suggestive of UTI, so offensive smelling urine, a bit more lethargic, off colour, low-grade fever, yes, absolutely. Now, they may be a baby that's vomited intermittently in the past and is vomiting more with their UTI. Fine, then look for a UTI. But for a child who's presenting with the very classical ongoing vomiting and distress essentially after feeds, then I would not be doing urine dip on all of them. It's actually quite hard to get an accurate clean catch urine. And you'll then get into a cycle of having positive microscopy, not knowing what to do with it because it's a mixed growth, etc., etc. So I would only look at urine if there's other indicators there.
I'm really pleased that you said that. Thank you. So do you have any key take-home messages or calls to action for primary care clinicians?
So there's some good information out there. Not saying this because I wrote the guideline, but there's a good guideline. It does point out the things to be wary of. It does give you a very clear treatment pathway and when to refer in. There is also a leaflet for families, and there is a link across to cow's milk protein allergy that I think is worth considering. My take-home message is that reflux is normal. It is present probably in every baby, and we only see it in those that are the most symptomatic. And therefore, it is about reassuring mum and baby and dad to accept that this is a stage of their development that they're going through. And if they're not having overt complications from it within the baby in terms of esophagitis or weight problems or feed aversion, or within mum being able to cope with a very upset, sad baby, then you can get through this by just supporting them and lifestyle factors. And that's absolutely okay to do that. We don't need to pharmacologically treat these babies every single time. It's okay to treat them. That's also a message you can give them. And we very clearly at secondary care level will be giving out a lot more pharmacological intervention than at primary care level. But if we know that they've had the right advice at primary care level and they've been doing everything, then that helps us make that decision fairly quickly. So having confidence in the knowledge of it as a diagnosis and supporting these families through it in the knowledge that it will come to an end. And it really will. And the families are so grateful to you when you get there in terms of looking back at the journey that they've had. And some of them involves lots of regular phone calls, touching base, weights here and there, talking through their anxieties. But actually you can get them through this and have a totally healthy child at the end of it.
Brilliant, thank you. And I think for me, some of the take-home messages were around that simplicity really and thinking about the complications, because actually if you've got hematemesis or a respiratory problem, we're going to pick those ones up. We're going to be sending them in.
Yeah.
But it's to think about it more simplistically as the weight loss or faltering growth and milk or food aversion. That's quite a nice simple way for my simple brain to remember.
Yeah, no, absolutely.
The practical tips as well with how to give the Gaviscon and the omeprazole, that's really helpful to know. The tip about the dummy, so that's a new one. That's one that I'll definitely be trying. And then the 150 mils per kilo per day. So I did remember there was a formula out there somewhere in terms of how much milk a baby should be drinking, but that's a really helpful one just to have back at the forefront in making sure that they're not overfeeding and therefore making the symptoms worse. And obviously you are co-author to our local guideline. Were there any particular parts of the guideline that you wanted to draw attention to?
I think the red flags is the box that I really want people to look at, because I think that's the bit where people may go down the wrong path at the start. So if you are not seeing any of the red flags, then have confidence in what you're doing. If you are seeing any of the red flags or you're suspicious or you don't feel confident to rule them out, then do get in touch. And you can do that by referring them in, or you could do something through advice and guidance, and we can often give some advice that way.
Fantastic, thank you. And I will link that guideline at the bottom of this podcast, along with ICON that we've discussed as well. Yep. Are there any other resources beyond that you think are helpful, either for primary care clinicians or for families?
So there's the parent information leaflet that's also available from UHBW. I did do a quick Google search, and actually loads of the hospitals have got very, very similar information out there. There are some forums and things, but none of them particularly give you anything more than what we've got available at UHBW. So actually, I would say that there isn't much else needed. I would link it to the cow's milk protein allergy one also, because I think that there is crossover and people do need to think about that as well. But otherwise, no.
Brilliant. And there's also a new milk-related guideline,
there is,
isn't there, that's just come out?
There is. So it's called Milk-Related Problems, and it goes through different ages of children having different symptoms. So it will talk about a true cow's milk allergy, it will talk about cow's milk protein allergy, it will talk about lactose intolerance, and it will talk about reflux, because there is a crossover with that. It's really brilliantly written and it's only just come out, so please do have a look.
Brilliant. Thank you very much. That was very clear and concise. And if anybody hasn't heard the separate podcast on cow's milk protein allergy, that's quite a nice natural follow-on to this, of thinking about the next differential to be considering if we're not winning with the reflux guidelines alone. Fantastic. Thank you so much, J-C.
You're welcome.
Do leave feedback and join me next month when I'll be talking to Dr Frances Hutchings, General Paediatric Consultant, who runs our local paediatric advice and guidance service, who's going to be sharing some of her insights around common themes and letters that she sees. The contents of these podcasts are for educational purposes, aimed at primary care healthcare professionals only. They do not substitute professional medical advice or consultations with healthcare professionals. Information presented is the opinion of the healthcare professional interviewed, based on their interpretation of best practice and guidelines at the time of the interview. It is the listener's responsibility to compare information given with up-to-date national and local guidelines. The BNSSG Training Hub, Ruth Bowen, and interviewees are not liable for any clinical decisions made as a result of this podcast.